Hello, everyone. We are sorry we're a couple minutes late, but we're going to get started now. So thank you so much for coming and attending our Ask the Experts. Let's talk about breast cancer webinar series. Today, our topic is going to be managing estrogen, answering treatment-induced menopause questions. And we are so excited to have Dr. Crystal Murray with us today. Dr. Murray is a hematological oncologist and medical oncologist at the Baylor Scott and White Cancer Center in Round Rock, Texas. She graduated from Texas A&M University School of Medicine, completed her residency in internal medicine and fellowship in hematology and oncology at Wake Forest University School of Medicine. Dr. Murray has been recognized as a top doc by Austin Monthly Magazine, and we are just thrilled to have you here today, Dr. Murray. Thanks so much for taking your time.
Yeah, thanks for having me. I'm excited to be here. I know that this is a topic that we talk about a lot in the clinic, and I spend a lot of time every day discussing these things. And so I think this will be a great conversation starter. So first, the definition of menopause, since that's what we're talking about. So this is the NCI, National Cancer Institute definition, and it is the time of life when a woman's ovaries stop producing hormones and menstrual periods stop. Natural menopause usually occurs around age 50. Obviously, with this presentation, we're not necessarily talking about women who are 50 or older. A woman is said to be in menopause when she hasn't had a period for 12 months in a row. And this definition does not address the issue of women who have had chemotherapy. So women who have had chemotherapy, that definition is actually 24 months. So if chemotherapy is what actually initiated menopause or the cessation of menses, it's 24 months, not 12 months. And so this is a timeline of what that menstrual period looks like over a woman's lifetime, starting with premenopause. And these are all ranges. Perimenopause, kind of 35 to 45, and that's when we're starting to see some alteration in estrogen levels and potentially even irregular menstrual cycles, more frequent, less frequent, maybe heavier. And then menopause is when periods actually stop. And again, 12 months without a period for women undergoing natural menopause and 24 months for women who have had menopause induced by chemotherapy. And then that postmenopausal time frame. So that time after menstruation has ceased completely. So this slide may be a little bit overwhelming, but these are all of the potential symptoms that women may experience with menopause. And some of these are much more frequent. Some of these are much less frequent. Everybody's experience is a little bit different, right? If you start talking to your friends who are older who have been through this, or friends who have had breast cancer who are on medications or had chemotherapy that induce some of these symptoms, everybody's a little bit different. And so while you may be experiencing a lot of these symptoms, your friend may have very few. And so we'll address some of these things. And then if y'all have other questions about some of these things that I'm not discussing at the end, we can talk about those questions. So who are we really talking about today? I think that really anybody who has had breast cancer, this is relevant for. So whether you're premenopausal and chemotherapy has induced menopause, or we've induced menopause intentionally, this is certainly relevant. Postmenopausal women with breast cancer, even if somebody is postmenopausal before they are diagnosed with breast cancer, I think this is relevant since some of our medications can induce menopause symptoms even after the fact. And I think it's relevant for women who have estrogen receptor positive and or estrogen receptor negative breast cancer. So really anybody may be experiencing some of these things, and this may be relevant. This was a study here, this quote down at the bottom, that was looking at women who have had chemotherapy and symptoms associated with menopause. And all women, regardless of menopausal status, premenopausal, postmenopausal, reported an average of 11 co-occurring symptoms. And so truly, this is relevant to everybody, regardless of the actual menopause status of somebody. So this how are they, why are they experiencing these symptoms? And so this is important for a couple of different reasons. I think understanding the how helps us understand the why and helps us kind of have a mindset of why this is important. And so the how of it is incidental. And so with this, incidental would be a secondary or truly unintended effect of treatment. And so this would be women who have had chemotherapy-induced menopause, or I think, again, relevant to everybody, even if they are premenopausal or postmenopausal, may have symptoms of menopause due to hormone blockers, whether tamoxifen or the aromatase inhibitors. This here is a chart that is looking at the rate of chemotherapy-induced amenorrhea by age and time since chemotherapy. And so if you look at that darker graph there, women who are over the age of 51 clearly have a higher rate of chemotherapy-induced amenorrhea. And then you look at the lighter graph, the less than 40 years old, and their rate initially at 6 months is relatively high and then dissipates over time. So the older somebody is, the more likely they will have chemotherapy-induced menopause. So that was incidental, so not necessarily intending from a medical standpoint to put somebody into menopause. But then there's also the intentional. So why would we intentionally, or how would we intentionally create menopause in somebody? So ovarian suppression, and that's usually medication, so Lupron or Gaserelin, which is also Zoladex. And so those are monthly injections that we give to suppress ovarian function. Sometimes we'll do ovarian removal and oophorectomy. And then sometimes ovarian radiation, though I haven't used that anytime recently. And so we may intentionally put somebody into menopause and create some of these symptoms. Now the why. Why are we doing this? So BRCA mutations, other genetic mutations, ATM, CHEK2, PALB2, Lynch syndrome. So these mutations, and there's some others as well, increase the risk of breast cancer by age, as well as ovarian cancer. And so in those folks that have mutations that increase the risk of ovarian cancer, we can lower that risk significantly by removing the ovaries. When we do that, we're putting them into menopause. But we can also lower the risk of breast cancer occurrence in those women by removing the ovaries as well. And so we may intentionally remove ovaries and put them into menopause in order to reduce the risk of them developing other cancers. And then this is, y'all may have heard about soft text. I'll just go over this briefly. So these were studies that were done a number of years ago and looked at higher risk estrogen receptor positive cancers and premenopausal setting, and took those women after they had had their initial therapy, surgery, radiation, plus or minus chemotherapy. And what it was trying to evaluate is, was there benefit to ovarian suppression with tamoxifen or with aromatase inhibitors, and in this situation, they used exemestane, compared to tamoxifen alone. And so there was a very clear difference in recurrence rate or disease-free survival by doing ovarian suppression, whether that was surgical or whether that was medically induced. And so we may recommend that we intentionally induce menopause in a premenopausal woman in order to reduce the risk of this breast cancer coming back, especially if they are higher risk. The other thing that came out of this was that there was a clear difference in benefits across age groups. And so younger women under the age of 35 had a higher benefit of ovarian suppression compared to women who were older, 45, 50, closer to that menopause time. So now we'll talk about the what after we talked about the who and the how and the why. So we'll talk first about the medical problems that come from it, and then we'll talk second about some of the symptoms, the everyday things that women may experience with this. And so one of the big things is bone density loss. And so some of you may know that the aromatase inhibitors can induce bone density loss, but going through menopause early, again, whether it is medically induced or whether it's surgical, can accelerate bone density loss as well. And so here is a little cartoon of what that might look like as women go from bone thinning over here to osteoporosis. And the issue with that is increased risk of fractures later on down the road. And so that's really what we are trying to avoid, is fractures as women get older. And so the question is, what can we do to avoid this or to reduce the risk? And there are certainly some lifestyle modifications people can make if they're not already doing them. Not smoking, which we would recommend anyway, as that increases the risk of breast cancer, but also increases the risk of other cancers. Taking vitamin D if appropriate, and I always monitor vitamin D levels. Taking calcium, so about 1,200 milligrams of calcium per day. Now, dietary calcium is probably better. So if somebody's eating a lot of dairy products or other calcium-containing foods, then that's actually better than taking a supplement. But if you're just not getting a lot of calcium in your diet, which a lot of people don't, then calcium supplementation is recommended. And then weight-bearing exercise. So I'm going to talk about exercise a lot through all of this because I do think it's helpful for a lot of things. But that weight-bearing exercise helps increase that pressure on the bones, which helps to give that bone stimulation to continue to make bone. And so weight-bearing exercises, what I'm talking about are weightlifting or walking, and walking is really the most common thing that women will do. Running sometimes. What is not a weight-bearing exercise, even though it's great, is swimming, and then cycling does not really give your bones that increased stimulation that they need. And then we have medications. And so if women have osteoporosis already or have significant osteopenia, so thinning but not yet meeting criteria for osteoporosis, we may recommend starting some medications in addition to the lifestyle modifications. And so some of the medications, bisphosphonates, what falls under that category is going to be Fosamax, if you've heard of that, Boniva, which is a monthly oral medication. And then there's Reclast or Zometa, which is the IV form of that. Tamoxifen actually decreases the risk of bone density loss. And then Raloxifene is actually sometimes used in settings, even apart from breast cancer, in order to reduce bone density loss. And then another medication that y'all have probably heard of, Prolia, denosumab, Xgeva is the other name for that. So it's a different mechanism from the bisphosphonates, but a really great medication, and likely a little bit better in terms of efficacy than the bisphosphonates. The other thing that I'll mention is with the bisphosphonates, there were some studies that were done a number of years ago that looked at women who were postmenopausal, estrogen receptor positive, who were higher risk, so had had chemotherapy was really how that was defined. And they were given IV bisphosphonates, primarily Zometa. And there was actually a benefit in reduction of breast cancer recurrence. And so some women actually may receive that medication even if they don't have thinning of the bones already. So there may be some additional benefit with regards to cancer treatment. Cardiac disease. So we know that menopause at an early age increases the risk of heart disease. This chart here is not looking at women with breast cancer in particular, and it's not looking at women with chemotherapy-induced menopause. It's looking at all women. So this was a large study that was done and looked at women who underwent early menopause and those who underwent menopause at an average age around 50. And there was a clear difference in the risk of heart disease between those two groups. So what can you do about cardiac disease? Again, exercise. This is really going to be, I think, one of the best things that all of us can do to help us long-term. Avoidance of smoking, that increases the risk of all sorts of things, including heart disease. Maintaining a normal weight or BMI. And then I think it is also important to make sure that somebody has good routine health checks with their primary doctor and or a cardiologist if they're really high risk for cardiac disease, to make sure that we're maximizing any kind of medications they may need to decrease their risk of heart disease. Okay, so now that was talking primarily about the major medical issues that come up, which may not be things that you experience on a day-to-day basis, but are still really important and things that we need to be talking about in the clinic. But this is really where I think most of the interest is what are the things that you're feeling on a day-to-day basis that affect your quality of life? And so we'll walk through all of this, and I had some questions sent to me ahead of time, and I think I'll try to address most of those as we go through here. So hot flashes. Hot flashes are very common and can be, for some women, quite debilitating and have some significant other things that they lead to. And so for quality of life purposes, this is something that's really important to address. So what medications are there to address this? And so my absolute favorite is oxybutynin. Oxybutynin, the other name for it is ditropan, was originally designed for urinary incontinence, but the mechanism by which it works also helps with hot flashes. And so this is really my go-to medication. This study was presented at the San Antonio Breast Cancer Conference, I believe 4 years ago. And you can see that red line, that's the placebo. So women who did not receive any active medication. And they did have a slight decrease in the hot flash symptoms from baseline. And then you see that blue dotted line is the oxybutynin taking 2.5 milligrams twice a day. And then the solid blue line, women taking oxybutynin 5 milligrams twice a day. And clearly significant benefit in reducing hot flash symptoms with that oxybutynin. Prior to this study coming out, we tried all sorts of other medications that I think were pretty hit or miss. So antidepressants certainly were one of my go-tos previously. Effexor, venlafaxine is the other name for that one. Prozac, Paxil, all of those are reasonable to try. Clonidine we used as well, and then gabapentin. When I am meeting with somebody and they are experiencing significant hot flashes, we talk about all of these things. And I ask some other questions. If they have some co-occurring depression or anxiety, or if they're having problems sleeping, then I may choose one of those other medications. But if the major issue is really the hot flashes, oxybutynin is where I go with that. There's also a long-acting medication for long-acting form of the oxybutynin. So you actually can just take it once a day. So it makes it really easy. You can just throw it in with whatever else you might be taking, as opposed to having to take it twice a day. And then other things that people can do, because there are some other things. So wearing cool layers, wearing looser fitting clothes, because closer fitting clothes are not quite as cool. Having a fan by your bedside. There are cooling mattresses. And so, or even cooling pads that women can use if the primary issue is at night. And then there's some data to back up using acupuncture. I have certainly had some women who have tried it. Some have found it helpful, some haven't. Everybody thinks it's relaxing. And so if it is something that you're interested in, I think it's a great thing to try if you especially don't want to take extra medications. This was the same study looking at oxybutynin, and they didn't, in that particular study, look at all of the other medications, but they looked at historical controls. And so it's really clear on this that oxybutynin outperformed all of those other medications. They also looked at supplements, and this has been looked at in several studies. None of those other supplements were found to be helpful: soy, flaxseed, black cohosh, magnesium, and vitamin E. So sexual changes. I think this is really important to talk about, and we don't talk about it enough in the clinic. I think it can be embarrassing sometimes to talk about this. And so libido certainly decreases with menopause for a lot of women, and some of the medications that we utilize, the hormone blockers, can cause decreased libido. Unfortunately for women, there's not really a whole lot out there to help with this. There's no clear medications to help in women who have had breast cancer. And so a lot of it really is about managing your mind around this. And I think it could be helpful to talk to your doctor about it, but then maybe even have some counseling or a sexual therapist that can help you kind of figure out how to manage your mind around libido. Vaginal dryness is also really common. And so this photo here shows you on the left side how the uterus and the vagina itself look in the premenopausal setting. And then you can see over here on the right side how all of that tissue thins out, and the vaginal canal actually shortens as well. And so with that, women can be experiencing pain with intercourse, recurrent urinary tract infections as well. And so there may be some significant quality of life issues. Some women will also even have daily burning or itching. And so this may be really impactful, even just for day-to-day quality of life. And so how to manage the vaginal dryness: lubricants, good quality lubricants can be helpful, silicone-based primarily. Non-penetrative sex is an option if that works for a couple. Vaginal estrogen. So this is something I recommend that you have a conversation with your oncologist about. We don't have a ton of data, unfortunately, looking at vaginal estrogen use in women with breast cancers, estrogen receptor positive breast cancer in particular. There have been some small studies that have looked at this. Those small studies did not show an increased risk of breast cancer recurrence. They did show improvement in quality of life. And so I think it's a conversation to be had and to discuss with your oncologist what risk you're willing to take if there is a risk of increased cancer recurrence. And then there has also been a study looking at hyaluronic acid, which is a kind of like a gel. I don't think that you could find it readily at Walgreens or Walmart or anything like that, but you can get it online. And so there was a study that was done that showed decreased symptoms of vaginal dryness with hyaluronic acid. So skin and hair changes. So what can happen with menopause? Thinning hair. Some of the hormone blockers also can cause thinning of the hair, brittle nails, dry skin. Management of this, I think, can be challenging. Definitely drink water, lots and lots of water. Most of us don't drink enough water. And then make sure that you're using gentle soaps, things that don't have a lot of fragrance added, a lot of dyes added. Biotin sometimes can be really helpful for the hair and the nails in particular, collagen potentially as well. And then really minimizing the things that we all do that can cause damage to the skin and the hair. So minimize all of the products and the dyes in particular for hair and minimizing all of the processing that we do can be actually really much better for our hair and skin and nails. So sleep changes are huge here. So not only can menopause affect sleep, but also hot flashes can affect sleep. And the problem with not sleeping well is it can cause all sorts of other issues. And so women can have difficulty falling asleep. They can have frequent awakenings throughout the night, and then they can have early awakenings. And these are, I put them separately because they need to be managed differently for a lot of women. So what's the result of not sleeping well? Well, irritability. I think we all know that when we don't sleep well, we're a little more cranky in the morning, a little short with our people, less able to tolerate stressors at work or at home. Obviously, fatigue, and then can certainly impact mental health, depression, and anxiety, and then cognition as well. And so when we're not sleeping well, we're not focusing as well, we're not able to complete complex tasks as easily. And so it can have some downward effects on the rest of our life as well. And so this graph here is looking at women, looking at a study of where women were in their menopausal status and the odds of them having each of these different problem sleeping. So the green graph was difficulty falling asleep. And you can see that that increased from early menopause to late menopause to postmenopause, was significantly higher in women who had undergone removal of the ovaries and had surgically induced menopause. Waking up several times a day was also an issue, or several times a night, and then early awakenings as well. And so this here is kind of just a graphic of all of the different things that we can do to actually help ourselves sleep better. That does not require any kind of medication or supplement. So a lot of us don't have great sleep hygiene. And so I think these are some good things to implement if you're really struggling with sleep, regardless of what your treatments are and where you are in menopause. And so making sure that your room is a good setup for sleep. It's dark and it's cool and quiet, that we're not eating before we go to sleep, because that can actually keep us awake. Not smoking, no alcohol before bed. Some exercise, moderate exercise during the day helps. No caffeine after noon, generally, maybe as late as 2, and you might have to figure out what your body can tolerate. Having a comfortable bed, again, a good sleeping temperature. So most people will sleep better with a temperature of 68 degrees Fahrenheit or less, and there's actually some data to back that up, some studies that have been done. Going to bed at the same time, waking up at the same time. And this is, I think, hard for a lot of us. And then the hardest thing is staying off of screens. We're on screens all the time, whether it's our phone or a computer or an iPad or a TV. And those things actually are stimulating our brain and telling our brain that it's daytime. And so ideally, we actually need to put those things down 2 hours before we go to bed. So mood changes, I know that this was a question that came up as well. Menopause itself, apart from the hormone blockers, can cause mood changes. And so irritability is probably the most common one, depression, and then anxiety. What other risk factors women have can affect whether or not they'll develop, or their risk of developing mood changes. And so women who have had prior depression or anxiety are at higher risk of having those mood changes during the menopause time. Women who had severe premenstrual syndrome when they were premenopausal have a higher risk. And then women who have sleep disturbances, who are not sleeping well, are going to be more likely to have some of these other mood issues. So what can we do about this? Counseling, I'm a big fan of counseling. I think that especially for women who have had breast cancer, there's a lot of other things that counseling can address in terms of thoughts and thought management. Medications, obviously, and so antidepressants, anti-anxiety medications may be helpful. Working to improve your sleep. And I think a lot of times we don't go to that first. We don't go to that unless we clearly identify that we're fatigued. But even just working on that and improving the sleep can significantly improve mood. And then lifestyle modifications, and it's a lot of these things are the same for all of these issues. So decreased alcohol. Alcohol intake can increase mood issues. Some people will use alcohol for kind of coping or making themselves feel better, decreasing that anxiety. But really, it's not helpful. It's helpful in the moment, but not long term. Exercise, especially getting outside, walking, running, can be really helpful for improving mood. But even just doing yoga or stretching inside and moving that body, that physical movement actually improves some of the neurotransmitters in the brain that impact mood. Meditation and mindfulness, I think, can be really helpful. And if you're not really sure what I mean by that, then I think that's where some counseling can be helpful as well. And I have a lot of women who, especially with the irritability, are able to increase their awareness and their mindfulness around how they are responding to people and how they're feeling, and manage the irritability without any further medications. Okay, I threw this in because I know that this is one of the big questions. This is not necessarily related to menopause itself, but joint pains, arthralgias, and then muscle aches, myalgias are really, really common in women who are on hormone blockers. I see them also sometimes in women who have finished chemotherapy as they're coming off HER2 targeted therapies in particular. And so I put this in here to try to address some of those issues. So what are the things that you can do to manage this? And again, exercise. I think exercise is great for so many different things related to breast cancer and breast cancer treatment. And so find what works for you. And even if you're somebody who has not had a routine of exercise in the past, start adding some things in, a little bit of a walk, or even just some stretching or some yoga. There's actually really good data to support using exercise in treatment of joint issues. You can always use over-the-counter medications, Tylenol. For the short term, you can use anti-inflammatories like ibuprofen. Not something we want people on every day for long periods of time, because that can have some other side effects that we don't want to have to deal with. And then prescriptions. And so Mobic is a prescription anti-inflammatory that can be taken once a day. Cymbalta is one of my favorites for joint issues. And so this is why when I talk to women who are having hot flashes or other symptoms, I ask some of these other questions about some of the other things they may be experiencing. And so Cymbalta we've used for a long time in chronic pain. And so fibromyalgia was really one of the first areas that it was being used. And so if women have hot flashes or depression and they're having joint issues, I think Cymbalta is a really great medication to try. Probably the most data behind that one, and a lot safer than taking ibuprofen every day. Acupuncture may be helpful for a lot of women. And then the other thing this is the most common reason why I change hormone blockers. And so for whatever reason, sometimes women will tolerate one of those hormone blockers better than another one. And so within the category of aromatase inhibitors, there's three different ones. There's letrozole, there is anastrozole, and then there's exemestane. And so we can switch back and forth between them. We know that they're all essentially equivalent in terms of how effective they are. And so I think that's a good kind of first step, is trying a different one, see if a different one is better. And then tamoxifen is another option. Women can have joint issues on tamoxifen, and I see that more in younger women, the premenopausal women. But the rate of joint issues is less with tamoxifen. It's not quite as effective as the aromatase inhibitors at reducing the risk of cancer recurrence. And so it's not typically what I start with, but I think it's reasonable if women are struggling with the aromatase inhibitors. So I think the thing to keep in mind is that we're all on the same team. And the ultimate goal is to reduce the risk of cancer recurrence with everything that we do, whether it's surgery or chemotherapy or radiation or hormone blockers or inducing menopause. And so that's the ultimate goal. However, you also need to be able to live your life, right? And so we want to make sure that whatever we're doing in terms of treatment is something that you can live with. And if you're really struggling with any of these things or other things, we want to make sure that we can alter things so that you can live with whatever it is that you're doing in terms of treatment. And so these are important things to talk with your doctors about and figure out, are there things that we can do differently so that you can live your normal life and enjoy the things that you enjoy doing. So I believe we have time for questions. So I will stop talking and let y'all ask questions.
Thank you so much, Dr. Murray. Yeah, we have quite a few questions, and you answered so many in your presentation, so thank you so much. So these are all a little specific, but I think it'd be great if you're able to share some of your thoughts on them. So have you heard of people using Tai Chi and other martial arts for weight bearing and for building bone?
I have, yes. So I've heard of a lot of people using Tai Chi for a lot of different things. I think it can be helpful even just to give you that movement and help with the joint issues, the muscle aches. But a lot of people also get a lot of relaxation out of it and mindfulness. And so I think it can be helpful potentially for a number of different symptoms.
Great. Okay. What is the link between oxybutynin and dementia?
I'm not aware of any link between oxybutynin and dementia.
Okay. So when you say higher risk women, what do you mean? I wonder how to determine if my doctor should induce menopause in addition to tamoxifen.
Yeah, that's a great question. So in the soft and text studies, the way that was defined was women who had been on chemotherapy. It is, I think, always a good thing to ask, and a lot of women with breast cancer aren't aware of that study. But I think that have that conversation with your doctor. Other kind of high risk features potentially are going to be enlarged lymph, or the size of the primary tumor and how many lymph nodes were involved.
Okay. How do you get rid of weight gain around the stomach area that's solely from menopause?
Yeah, I think the weight issue is really challenging. Yes, our bodies change with menopause. It's not a direct link, though, in the sense that there's a lot of other things that factor into weight gain. Certainly diet, alcohol, movement, genetics are a big part of that. And so I don't have a great answer for you, but there are some lifestyle modifications that most of us can do that would decrease that weight gain.
And in relation to that, someone just asked about using tamoxifen and gaining weight on that. I mean, is there anything that can be done for that, or any medication to prevent the weight gain?
Yeah, there's not a medication. I will tell you that most of the time, not every time, most of the time that I see women who have gained weight on tamoxifen, they haven't gained as much as they thought they did. And so when we go back and look at clinic notes and they've been weighed on the same machine every time they come in to see me, the weight difference is less than they actually thought it was. But most of the time I'll see that they were actually gaining weight before they started the tamoxifen. And so again, I think it's one of those situations where, yes, tamoxifen may be contributing to weight gain, but it's not the only thing. And so I have definitely seen women who have lost weight while they're on tamoxifen and gotten below the weight that they were when they were initially diagnosed with breast cancer. And a lot of that is going to be diet and movements. Now we know exercise doesn't necessarily cause weight loss. But I think that there are some positive effects on exercise in terms of how we eat. The most important thing I think in terms of eating is figuring out, addressing the emotional eating. I never thought I was an emotional eater until I started thinking about it and being more aware. And I was like, oh my goodness, I eat all the time for emotional reasons, happy, sad, depressed, bored, whatever. And I think that if we are more mindful about our food, when we're eating, why we're eating, that can be hugely helpful.
That's such a great point. And I just want to put a plug in. We have a new program called Compass Crew, and it's for all the BCRC clients who would like to work on their health and wellness. So there's lots more. So if you're interested, please look out for that. So a couple more questions.
Yeah.
She takes both oxybutrin and venlafaxine low dose. I guess she's asking if you take them both together.
Yes, you can.
Okay.
Yeah.
I thought gabapentin was for neuropathic issues.
Yeah, it is. And so gabapentin was originally designed as an anti-seizure medication, and it's just not a great anti-seizure medication. So we don't use it a whole lot for that. And then we started using it primarily in neuropathy, and it can be helpful, but I've also seen that it can be helpful for hot flashes. And a lot of primary care physicians are using it now to help people sleep. Really low doses, 100, 200 milligrams before bedtime. And so if I have somebody that has hot flashes mostly at night and they're having difficulty sleeping, I think gabapentin is great. And again, just fairly low doses. Gabapentin doses can go up to 1,200 milligrams 4 times a day. They can go really high. And so we're really talking 100, 200, maybe 300 milligrams. And for some women, that's completely sufficient to help them get better sleep.
Great, thank you. So natural menopause, age 32, estrogen until age 59. Now at 65, hot flashes are killing me. Letrozole didn't make them worse because they were already that bad. Any hope of them ever stopping?
They can. So we know that on hormone blockers, they typically get better after the first 6 months. And I had a chart in my presentation, even in natural menopause, hot flashes can improve with time. However, again, everybody is different. And so there are some women that go through menopause and literally never have a hot flash. And there are some women that have hot flashes into their 80s. And I don't know if that's helpful for you. But potentially, yes. And you may want to consider a medication to help with those if they're pretty significant.
Okay. In patients with history of low risk breast cancer and have had bilateral mastectomies and are having significant menopausal symptoms, do you ever recommend hormone replacement therapy?
Yeah, that's a great question. So I would only recommend or even consider hormone replacement therapy in somebody who has had, maybe they had a BRCA mutation, they had their ovaries removed, they had bilateral mastectomies. I think that's a very reasonable situation to use hormone replacement therapy. The other place I would consider it is in women who had triple negative breast cancer, truly triple negative breast cancer, and had mastectomies. I would never consider it in somebody who's had estrogen receptor positive or progesterone receptor positive breast cancer.
Okay, great. Thanks. We have a couple more. Are you good?
I'm good. Yeah. Let's keep going.
Okay. I am on Herceptin and Perjeta
Uh-huh.
infusions, so would like to know what the alternatives to that are. I'm also on Tamoxifen, so would like to know what the alternatives to that are. I'm early in the process, so want to know other possible options.
Okay. It's hard to say without having more information, but Herceptin and pertuzumab, Perjeta, are really standard of care in HER2 positive breast cancers in the setting of neoadjuvant, so before surgery, and then adjuvant after surgery treatment, usually for a year. There really isn't a good alternative to those. Very rarely, I will use only Herceptin and not the pertuzumab, primarily in women with smaller tumors and lymph node negative. And then we do have data that shows that using Kadcyla, TDM1 is the other name for it, after surgery in women who did not have a complete pathologic response, improved survival. It's not necessarily an alternative depending upon what your particular situation is, but it is something else that we'll use. In terms of alternatives to tamoxifen, there really isn't. So for the premenopausal setting, tamoxifen's really it in terms of having good data to show that it reduces the risk of cancer recurrence. And it does. It reduces the risk of cancer recurrence by about 50%. So huge bang for your buck for that medication. The true alternative to that would be to induce menopause and then use an aromatase inhibitor. Generally speaking, that's not going to address any side effect issues that women have on the tamoxifen. Inducing menopause generally isn't going to make somebody feel better than just being on tamoxifen, but it is an alternative.
Okay. We've had a couple questions around testosterone. There's nothing specific, or there's studies around testosterone, or
yeah. So
to help with the libido.
Yeah. So my answer is don't do it. The reason for that is that your body actually converts testosterone into estrogen. And so if you're taking testosterone replacements, that's essentially the same thing as hormone replacement therapy. And so you're, in theory, potentially feeding any breast cancer cells that may be there. I think it does help for a lot of things, but it helps primarily because you're feeding your body those things that it's missing, and that could make your cancer outcomes worse.
Okay. 45, been on tamoxifen for 4 years. Is tamoxifen causing perimenopause, or is it normal aging? Is it possible to know?
Yeah, it's really difficult to know. Tamoxifen can certainly alter your periods, and that's really the best indicator that we have of what's happening in someone's body in terms of their hormones. And then hormone levels can be altered by tamoxifen as well. So sometimes we'll check estradiol and another hormone called FSH, and tamoxifen can alter those. And so it's very difficult to know sometimes, but it may just be normal menopause as well.
Okay. And so what about, are there any natural forms of estrogen that you can use?
So there are some, and if you remember back to one of my slides about hot flashes, there have been several studies that have looked at various other supplements that have estrogen-like properties. For the most part, that data has all been negative. And so we haven't really seen a lot of benefit at reducing menopause symptoms from over-the-counter supplements. Now, for the most part, depending upon what it is in a particular woman's situation, I don't have a problem with them trying those, but I don't necessarily see a lot of benefit from it. So I don't recommend them. I don't say, hey, why don't you try this? But if they want to try it, I think generally speaking, it's okay.
Okay. Just one or two more. And thanks for ping-ponging all the different topics.
Yeah.
So what are your thoughts on the newest breast cancer index test? It supposedly lets you know if you need to stay on tamoxifen for more than 5 years.
Yeah. So I think it is definitely intriguing. So for other people that don't know this, breast cancer index is a test that's done on the tumor itself. And they do gene testing on it. They report that back to us. And the way that they report that back is there's a number that says, here is the risk of cancer recurrence over a period of time. And I don't remember what that period of time is. And then benefit or no benefit to extended duration of hormone blockers. And so this applies to tamoxifen as well as the aromatase inhibitors. I think it's, again, intriguing. I think the jury is still a little bit out on how reliable that index is. I do use it sometimes, especially if I have somebody that is really uncertain about whether or not they want to stay on it, but are willing to stay on it. Generally speaking, our data has shown that 10 years is better than 5 years in terms of hormone blockade, especially in women who are high risk. So more extensive disease, larger tumor, more involved lymph nodes. And these are all conversations to be had. I would not tell somebody, you have to do this. And so what I tell folks is, let's aim for 5 years. As you get closer to the 5-year mark, let's talk about what the new data are, because there's always new data coming out. And if somebody says, you know what, I feel nervous about coming off of it, I want to stay on it, great, stay on it. If I have somebody that says, there's no way I will continue taking this beyond 5 years, fine, let's stop at 5 years, knowing what the risks potentially are. But if I have somebody who's just really uncertain, they don't necessarily want to stay on it, but they would be willing to, that's a really good scenario to use the breast cancer index. I don't use it routinely on everybody, but I think there may be some value in those folks that kind of fall into a gray zone.
And insurance probably doesn't cover it, does it? Like, do you know that?
Yeah, I have not had any insurance issues. And so occasionally I have an insurance that will only pay for one molecular test. And so what I mean by that is any kind of gene testing on the tumor itself, breast cancer index, Prosigna, Oncotype. And so every once in a while they'll be like, nope, we already did that. And they're not actually validated for the same thing. And so they do actually have different uses in my mind. Generally speaking, I have been able to get a breast cancer index on anybody that I've requested it on and covered.
That's great. And yeah, one of the clients on the line said that they had it approved through their insurance. So yeah.
Yeah. I will say too, I've probably ordered it, I don't know, 15 times. And every single one of them came back saying that there was no benefit to extended duration hormone blockade. And that kind of throws up a big, maybe a little yellow flag for me, that they were all no benefit to extended duration. And yet our large studies did show benefit to extended duration. So I think that's why I don't use it routinely.
Okay. How risky or beneficial is soy?
We don't know. I think that's a hard one. Dietary studies are exceedingly difficult to do because there's so many different factors into what we eat, what we take in. And so I think we'll probably never have the answer on that. Or if we do, we're going to get multiple conflicting studies. And so a lot of times what I hear concerns about is soys and everything. Well, it's in a lot of processed foods. Generally speaking, I think we need to minimize our processed foods anyway. And so get rid of the processed foods. And then if you want to eat edamame every once in a while, I think that's totally fine.
Great. Last question, and we'll wrap it up. And please, y'all, don't forget to do the survey that's in the chat. So kind of parting, what are some good vitamins or nutrients that might be able to help us? I know you mentioned the calcium, but I think in a more general sense, if you can give us your thoughts, that'd be great.
Yeah. I mean, I think generally speaking, the best thing to do is make sure that you are getting all of your good vitamins and nutrients in your diet. And so if you have a healthy diet and you don't have other gastrointestinal issues that impede absorption, then you really don't need any additional supplements or vitamins. There are some things that we talked about that may be helpful for some symptoms, But generally speaking, if people are on a good diet and they're getting fresh fruits and vegetables and proteins that have amino acids that they need, you don't need anything else.
Again, Dr. Murray, thank you so much. This was so informative. We're getting great feedback, just saying thank you, just so helpful, and hope to have you back soon.
Great. Thank you, Sharon. I appreciate it.
Thank you. Take care,
Bye.
everyone. Bye-bye.